Great. Well, hello. Welcome to OBGYNs for Sustainable Future. We are so excited to have Dr. Preeti Mehrotra with us today. Dr. Mehrotra is an assistant professor of medicine at Harvard Medical School and the epidemiologist at Beth Israel Deaconess Medical Center in Boston. And there she helps to lead infection prevention and antimicrobial stewardship efforts. She is a practicing adult and pediatric infectious disease clinician. Her clinical, operational, and academic work is multidisciplinary and focuses on socioeconomic, ethical, and regulatory implications of infection prevention and control and antimicrobial stewardship efforts. And I feel like she is one of the only people who has this particular understanding in all these different spaces. She is presented internationally on regulatory policy issues relating to disinfection and sterilization, the relationships between infection prevention, sustainability, and the role of supply chains in this realm. And then in 2021, she was awarded the Stephanie Davis Waste Reduction Award and Scholarship by Healthcare Without Harm and Practice Green Health. I worked with Preeti a year ago now at this point. We were on a panel together at Queen Med, and everything she said just was new to me as a clinician in this space. And, we combat so much in terms of, infection control and that sort of thing, not combat, but, there's a lot of barriers. And I learned there's so much more that we don't know, I think, when we're not in that space. And so really excited for everybody else to learn what I've been learning. And so I'm going to go ahead and turn it over to Preeti. Thank you so much.
Thank you so much, Ali, for that kind introduction. And it's such an honor to be here. I'm really excited to be here as well. As Ali mentioned, I'm an adult and pediatric infectious disease physician. I'm also the hospital epidemiologist at Beth Israel Deaconess Center in Boston. OBGYN has a very near and dear place to my heart as somebody who focuses also on perinatal infections, having trained on both sides in infectious disease. So here to talk to you today about another passion of mine, environmental sustainability and infection control, friend or foe. I'm not sure I'm going to answer that question entirely today, but I think I'll give you some sense of kind of the complexity between the two and the relationship. And hopefully that will be a thought-provoking exercise for all of us. So I first want to frame the conversation in terms of understanding this tension that we speak of a little bit further. And I want to take you on a journey really by thinking about case studies between medical devices and personal protective equipment to acknowledge that tension and to frame the conversation. And so on the one hand, in infection prevention, we know that transmission-based precautions, principles of disinfection and sterilization are really the cornerstones of our work. And was mentioned, infection prevention is usually in the position of supporting single-use devices, disposable equipment, because we are usually the ones at the table saying we need to decrease, if not get rid of, transmission risk via those devices. And yet on the other side, we know that healthcare is an incredibly carbon-intensive sector, and that we know to address climate impact, we need to have multilateral, multi-sector change. We need to think about regulatory incentives, and of course, we need to think about political will. And so how do we acknowledge and balance all of those competing priorities together? So I think to really frame the conversation, at least what I really aim to do is try and always offer perspective about what infection prevention is thinking of when they are talking about medical devices. And so if you forever talk to anybody in infection prevention about environmental sustainability or transmission risk of devices, they're going to be referring to this framework called the Spalding hierarchy or criteria to help stratify patient safety risk and transmission risk. So starting from the bottom of this graphic, you see something called non-critical instruments. Those are really instruments or devices that come into contact with intact skin. So think about the blood pressure cuff, think about the bed handle or railing. Those require the use of something called low-level disinfection, which is that typical purple top or gray top wipe you might see in your medical facility that's used to wipe down a space. Those, from the infection prevention standpoint, pose the least risk to patients. The second is something called semi-critical devices you see above that. And those are devices that come into contact with mucous membranes. And I think the best and most common example for this audience is probably the intracavitary probe. So the device that you use for transvaginal ultrasound, right, comes into contact with mucous membranes. And so how do we think about disinfecting those devices? We use something called high-level disinfection, which is basically a fancy word for the chemical process that is involved with decreasing bacterial burden on an instrument by at least 10 to the 6th log reduction. So getting rid of all the bacteria, viruses, and fungi that might be on that probe by using certain chemicals. And that process is called high-level disinfection. Now, high-level disinfection isn't complete. It's not the strongest, so to speak, of disinfections because what you're leaving out of bacteria, fungi, and viruses is spores specifically. And so how do we tackle spores and do greater disinfection? That's achieved via sterilization. And sterilization is at the top of this hierarchy. That's reserved for instruments or devices that come into contact with sterile body sites. So thinking about all the instruments that you're using in the operating room, those usually go through a sterilization process, and that requires above a 10 to the 6th log reduction. By how much is potentially variable and quantifiable by different methodologies and by different techniques, and is also thought to be sporicidal, so kill spores. So this is the framework that infection prevention is taught, and the framework via which they talk about transmission risk or transmission from medical devices specifically. It's very old. There is a school of thought that it needs to be updated. I am a believer in that. But this is what is sort of convention. And so when you take that framework, there are really seminal historical events that have occurred that shape how we think about Spalding criteria and why we think about it. So not surprisingly, the HIV epidemic really brought to bear bloodborne pathogen exposure, bodily fluid exposure, and that really increased the emphasis on, in infection prevention, thinking about personal protective equipment, standard precautions, universal precautions. And then I think the less talked about historical shaping of Spalding criteria, unless you're in the infection control community, but one that I really seek to talk about and bring to a larger audience is a series of outbreaks that occurred between 2012, 2015 of something called carbapenem-resistant Enterobacteriaceae, which is a very resistant organism that was thought to be transmitted to patients via incompletely disinfected duodenoscopes. And that resulted in significant patient morbidity and mortality, patient deaths. It launched this Senate testimony to the Health, Education, Labor, and Pensions Committee about medical device safety and medical device failures in regulation. And it really changed the regulatory landscape when I think it comes to disinfection sterilization, because it brought more regulatory might to this conversation about how do we keep our medical devices safe within hospitals and clinics where they're used. And so it was from these series of about 25 outbreaks that really intensive post-marketing surveillance program developed, that the FDA and the CDC in a joint venture finally started launching joint investigations into manufacturers and really sought to disclose what the conversations were that they were having with manufacturers. So from these outbreaks alone, there were, for 2 duodenoscope manufacturers, 6 reprocessing updates to how those duodenoscopes should be cleaned. There's 12 general communications just about these two duodenoscope manufacturers, and there's 16 public correspondences to these 2 manufacturers that were implicated in these outbreaks. And so that really changed how disinfection and sterilization were thought about in hospitals, and of course, how it was thought about by hospital accreditation programming, so Joint Commission, for example. And then, of course, I think goes without saying that the COVID-19 pandemic has also brought to bear, again, conversations around cleaning and disinfection. And so all of that has shaped now the market that we're in. So there is this need, there is this feeling with emotion behind it, and there is true risk that has occurred from reusable devices. And so there was this feeling of there needs to a necessity for the single-use market. And so after that advent of outbreaks in that 2015 timeframe and that huge post-marketing surveillance timeframe, it's not surprising that by 2019, manufacturers started having conversations about making duodenoscopes with disposable parts. And now I would say there's actually a completely disposable, completely 100% disposable duodenoscope. Much of that work was actually started at my own facility. And then you can see that that launched a cascade of events. So in 2021, you see that the FDA starts to question sort of some of the reprocessing around flexible bronchoscopes and launches an FDA safety communication. And then recently in 2022, again, an update to reprocessing methodologies for ureteroscopes. And you can see how now there's this public-facing relationship between the FDA and manufacturers to really understand if the disinfection instructions for these devices are sufficient and can be done appropriately. And so you can see that I'm probably not making a really great case already for reusable devices. And it's because I really want to be clear about the trade-offs, right? And the landscape in which you're going to probably be maybe talking to your infection prevention colleagues. To clean and disinfect these devices, the instructions for use to do that, there are literally booklets to manuals to do that work. And that is labor intensive, time intensive, requires an incredible amount of training. Sometimes these IFUs, instructions for use, as they're called, for people in the know. If you ever want to impress somebody in infection prevention, just say IFU and they'll know that you know the speak. They can be upwards of 100 pages. And so it's not easy work. And so there's real difficulty in training and real investment that's made in doing the training for individuals who are disinfecting and sterilizing our equipment. There is real estate for all of the equipment that goes into reprocessing these devices. So think about your sterile or central processing departments, or satellite clinics that need to do reprocessing for scopes that are used as part of clinics. There's capital cost in buying those reprocessors and providing preventative maintenance. And then there's also environmental concerns for those reprocessors themselves. So there's water use and energy use associated with those reprocessors, the chemical use, the chemistry that's different for each of these different kind of high-level disinfection sterilization programs. And then there's, of course, manufacturing and material cost. And so all of this to say is that it's really complicated. And I think that what we consistently lack is data. And if you remember nothing from my presentation, I hope that you remember IFU, but two, that data is really scarce, but absolutely necessary, and we need more of it. So many of you are probably familiar with the concept of life cycle analysis, or LCAs, but this is really thinking about the device from what we call cradle to grave, or cradle to grave analytics. So first off, what are the raw materials that are required to make a medical device? What are the energy and material requirements to manufacture the device? What are the requirements to then distribute that device, perhaps nationally or internationally in some cases? How is that device used? Is it thrown away once? And then how is it disposed of or recycled? So really thinking about the whole life cycle of the medical device itself. And so the LCA methodology is really the bedrock for a lot of the conversation around single use versus reusable devices. And so there have been plethora of studies, but they all kind of show sometimes the same things, sometimes different things. And so, I think the case needs to be made that we need really large scale LCAs with decision analyses to really get an accurate understanding of climate and financial impact. So in this study, for example, done by Jody Sherman et al., who's really one of the pioneers in using life cycle analysis and assessment, we not find a not surprising conclusion that there's a huge environmental impact. Carbon CO2 equivalents are markedly increased when using single-use disposable laryngoscopes versus reusable. That you find in this study looking at bronchoscopes that the energy impact and the reprocessing impact of PPE for reprocessing bronchoscopes far outweighs perhaps the carbon equivalents for single-use bronchoscopes. And then there's this study, for example, that shows when you look at ureteroscopes, maybe it's comparable when you compare single-use versus reusable ureteroscopes. All of these are giving us slightly different messages. And so again, needing to shift the frame and thinking about this on a much larger scale. I wanted to call out two studies that I think are particularly impactful for this audience, which I believe are actually already on your website. And so the first is this study looking at environmental impacts of looking at the hysterectomy procedure itself, all varieties, abdominal, vaginal, laparoscopic, and robotic, and done by Cassandra Thiel and colleagues, who's again another one of the pioneers looking at life cycle analyses. And you can see here that far and away, it's a busy slide, but I wanted to emphasize these figures for you, that the production of disposable surgical instruments, which is basically these green bars in this graph, far and away surpass in every single kind of hysterectomy that you can do the amount of CO2 equivalents and the percent categorization of impact on the environment. So huge impacts when we use single-use instruments, and that thinking about ways to mitigate that by encouraging environmental manufacturing or utilizing reusable instruments or third-party reprocessing would go a far in decreasing the CO2 equivalents of the surgery itself. Now there are others avenues, but I think these are a little bit more complicated. So thinking about the HVAC in the environment, that's not use in the operating room, that's not unique to hysterectomies, that goes for every single surgical procedure. And again, weighing the infection control risk, you can imagine that in a pandemic, nobody's going to want to touch air changes per hour in an operating room, for example. Now, to be fair, this is positive pressure and not negative pressure, but there's still significant HVAC considerations that need to be thought about, especially for ORs that might be reserved for traumas that might need to be always in use. Of course, the conversation about anesthetic gases, about disposable drapes and cottons, those are ones that are going to have impact across all surgeries, not just hysterectomies. But I thought this study was particularly unique because it did it across all methodologies for the way hysterectomies can be done. And the second is looking at the carbon footprint analysis for disposable versus reusable specula. So again, comparing acrylic specula versus the stainless steel. And at all parts of the life cycle, again, looking at raw materials versus the manufacturing, the distribution, the single use versus multi-use, and then again, the recycling and waste management of the specula itself and the packaging. And you can see in totality, this blue line represents the total life cycle carbon footprint of the acrylic versus the stainless steel. So much higher carbon footprint, of course, of the acrylic. But then more importantly, at every single stage in the life cycle, right, the acrylic has a potentially higher reuse than the reusable. So I think really impactful for this audience. And I think probably a conversation that many of us, I know I've certainly been a part of it in trying to support my my colleagues in the sustainability front in OBGYN offices and hospital settings. So how do we kind of bring all of this tension together? I would posit that I think that regulators and manufacturers need to be part of this conversation with us. And so, um, that's not easy because I think, as Ali mentioned, we're already in silos in thinking about this topic. And so bringing them into this conversation, having providers like yourselves, having infection prevention experts, having manufacturers and regulators at the same table is, a rare event. The last time it really did happen was when there was that post-marketing surveillance for those harm events that happened. And we need to change the frame of having it not just happen that we're all at the same table from a harm event, but preventatively thinking about how we can all measure climate and financial impact, of course, together. And so, in what I think was a show of rare but great collaboration, the FDA and the EPA came together to look at ethylene oxide, which is a sterilant that is often used that has some harmful occupational hazards associated with it. And so the EPA was involved in launching engagement efforts about looking at ethylene oxide, but at the same time, the FDA came to the table and said, if we're to take this one sterilant potentially out of the equation or use it less frequently, then we need to think about other ways that we can sterilize equipment. And so we need to incentivize manufacturers and regulators and scientists to think about what are other chemistries, literal chemistry, that can be used to sterilize equipment so that we're not just all living in a world where we're all shunting to the development of single-use products and using single-use products, because it's very tempting to head solely in that direction.
Hey,
So
Preeti, while you're on this slide, is the problem with ethylene oxide the manufacture of the chemical itself, the application of the use and sterilization, or both?
I would say that the occupational risk is with the use of it itself. Um, but I think that it's such tried and true methodology that most manufacturers will throw it in there as a option for sterilization. And so because it's an easy option, there's been less thought that's being put into what are other ways that as a manufacturer, we could also think about other sterilization techniques. And so I would say it's really twofold, but the bigger and the more common issue you're going to hear about ethylene oxide is the occupational hazard risk associated with it. And that's what the EPA has really been working on itself. Hope that answered your question. Happy to
Yeah, for some reason I associated it with reports out of Cancer Alley in Louisiana and populations that live near where it's also manufactured, but maybe I'm confusing that.
I see what you're saying. Yeah, in terms of the risk itself, it's more well studied for the individuals who are doing the sterilization work. But to your point, I can't imagine that the risk isn't there for the makers of it itself or those who are close to it.
Yeah, and Myra says in the chat, ethylene oxide carries risks to the surrounding communities. So yeah.
And so shifting frame from medical devices, I would probably not be a good hospital epidemiologist if I didn't also talk to you about personal protective equipment and the environmental impacts associated with personal protective equipment. And so many of you may be familiar with what's still a fairly controversial topic, which is the heterogeneous use of contact precautions for gowns and gloves for patients who are colonized with MRSA and VRE, methicillin-resistant Staphylococcus aureus, vancomycin-resistant enterococcus. And so, there's still a great debate about that, including in the infection prevention community. At my own institution, we transitioned away from using contact precautions for patients who are colonized with MRSA and VRE back in 2016. And a study that was done by my colleagues, Schrank et al., not surprisingly, found that there was significant reduction in the monthly expenditures for gowns and gloves when you just got rid of doing that practice altogether. And so it's certainly something that I try and encourage any and all providers to have conversations with their infection prevention and hospital epidemiologists about, because I think it's only with more conversation that you're going to engage, that you're going to encourage this national conversation. I think I'm obliged to tell you that in the Society for Healthcare Epidemiology professional guidelines, this is still listed as a practice recommendation to use contact precautions, but I can also tell you in practical reality that many institutions have let this go by the wayside. Again, purely because we found that the most important way to prevent infection transmission is by hand hygiene. So I also would not be a good hospital epidemiologist if I didn't say, take every opportunity to say, clean hands save lives and do your hand hygiene. So this is also not a surprising study, I think, to any of us, that of course there are environmental considerations when considering when we have to use contact precautions, reusable versus disposable gowns. And so at one healthcare facility, it was found that compared to a disposable gown system, the reusable gowns showed a 28% reduction in energy consumption, 30% reduction in greenhouse gas emissions, and of course a 93% reduction in solid waste generation. And so any opportunity you can get, so also comment on reusable versus single use gowns, I would encourage you to take that opportunity. And so how do we bring this all together? I also posit that I think really this conversation that we've had, and hopefully I've showed you some of examples or case studies of the tensions, is one where we have to stratify risk together and think about relative risk reduction. So changing the frame from everybody in the value chain and thinking about the linear cycle and really bringing back into focus a term that I think many of you have already heard, which is the circular economy. And so thinking about at every step, how do we take resources and even at every stage, including production, think about rethink and redesign and reduction of items that need to go into production. And then in the consumption and use phase, how do we reuse? How do we repair and remanufacture? And of course, how do we recycle and reprocess? And then limit the amount of waste so that there's recovery between use and waste. And there's this conversation, I think, is really just starting in earnest. So ST91 is a standard that infection prevention often refers to when thinking about cleaning and disinfecting scopes of all varieties. And you can see that we're starting, even in that conversation, to change the frame from all scopes need to be disposable because there's infection risk with most scopes, to maybe there's some higher risk scopes than others, right? Maybe there are endoscopes are the most complex, for example, because they have elevator mechanisms, because we know that the most microbial burden is associated, for example, with an endoscope or a duodenoscope and others. So again, thinking about how do we risk stratify in scopes itself, which I think is a conversation that's really just beginning. How do we change the methodology for testing and looking at residual organic matter that might be still left on a scope? And then having an honest conversation about personal protective equipment. I think, we all probably had to use elastomeric respirators potentially in some shape or variety during the pandemic. And so do we need to change the frame of how we think about PPE and personal protective equipment strategies when there might be crisis standards versus conventional standards of care, for example? So I think all of that is to exemplify having an honest conversation about risk together so that neither one party is saying there is zero risk or there's always risk. And I think that's a very difficult conversation to have, but I think it takes people like us partnering together to have that conversation meaningfully. So how do we forge collaboration? I think Stericycle, for example, is a company that's involved with a lot of medical waste management and regulation that many hospitals and clinics partner with as vendors. And so this is an example of the sustainability services that they offer if your facility uses these, having a conversation with that person who's managing your vendors about the sustainability practices that your vendors have or may participate in. Looking at outside organizations like Practice Green Health and thinking about the procurement strategies and all these other resources that they have available so that you can arm yourself to have a better conversation with your infection preventionists or with your supply chain folks. And then looking to your own institutions and understanding on the inside, for example, are there environmental sustainability initiatives where you're already working, which I'm sure all of you are already familiar with or perhaps even leading. And so I think all of those are incredibly powerful, but certainly more powerful in numbers and more powerful if all of us are at the table together. And so I hope I've created some situational awareness for you. I think if you are involved with talking to environmental sustainability program managers, I think sharing your goals and obstacles and visions with them and with your infection prevention programs, of course, working with your infection prevention programs, so seeing this hopefully as allies and not just barriers, I hope, so that we can establish partnerships together. As clinicians, all of us need to be having conversations, I think, with our colleagues in infection prevention and clinical engineering whenever we're trialing new equipment and seeing if it's there are sustainable options or reprocessing options. Being exposed to our colleagues in procurement and supply chain and understanding what's coming into sterile processing and what are the demands on our sterile processing experts. And then knowing that our sterile processing colleagues are beholden to certain regulatory changes and updates. They are the ones who are going to be hearing the most about those IFUs, those instructions for use, about those FDA warnings and changes to IFU. So their mindset and change of frame is going to be looking from that perspective. And so I'm hoping that we can embrace change together. I think that infection prevention control, we are in a position to influence policy and regulation, but I think to do that meaningfully, we need to start having it within the context of thinking about risk stratification. I think that sustainability teams and infection prevention teams need to collaborate. I think we probably are not doing enough, and spoiler alert, publication coming your way soon about kind of the lack of exposure between those two groups together. And so I'm hoping to change that conversation and at least increase the exposure of IP groups to environmental sustainability groups, both within and outside their institutions. I think we need data so that we can assess really the true global financial and environmental impact and trade-offs associated with single-use equipment. And then I think all of us as clinicians that are working in healthcare settings need to be mindful of thinking about, we didn't really touch on this, but water and ventilation as really kind of the next frontiers in building design. And so bringing our feedback to that table. And then hopefully that, all of this together will propel national and global partnerships between sustainability and infection prevention. So that was all I had. I'm so thankful that I got the opportunity, and feel free to reach out anytime. I, of course, wouldn't be able to talk about any of this if I didn't pay gratitude, of course, to my own team in infection control, and of course to my environmental and sustainability team here at BI. So thank you. Happy to take questions.
Thank you so much, Preeti. Excited for your new publication. Please email us. We will be the first to read it, and then we'll, of course, widely share it with our group.
Thank you.
I do have some questions, but before I dive into mine, I want to just invite if anybody else on the call had some questions that they thought about as we heard the talk.
Yeah, raise your hand, Heather or Myra, if you want to say anything.
I would love that, a question. Hi, thank you so much. That was such a great talk. My name is Mara Zlotnick. I'm an OBGYN at University of California, San Francisco. And right now I am part of a group, both internally, but also out the UC system, trying to get the campuses to decarbonize. And so basically right now the focus is to stop burning fossil fuels on campus. And one of one of our hospitals has a generation plant that is used for steam, part of which is used for sterilization. And so, you know, how in the sort of landscape of ethylene oxide probably going away or being less available and not sure what would replace it, how important is steam sterilization for OR equipment and other?
Yeah, it's a great question. So I would say by and large, all central and sterile processing departments will definitely need steam in some variety or shape or form as part of their program. I think that the heart and the meat of the question you're asking is like, what is the carbon footprint of your central processing or sterile processing department? And that is tied back to the amount of single use and the amount of disposable equipment that's used in operating rooms, and also what what surgeries and at what volume are happening in the first place. Because I think there's all sort of heterogeneous mix and match varieties that I think are part of this conversation that need to be risk assessed, right? So it's probably very appropriate to use, in the rare cases, for example, maybe single-use equipment. And then there are other perhaps higher, larger volume cases that might be occurring where the sterilization is difficult, where steam is most likely a part of that conversation. But then you want to be asking yourself, and what the sterile processing department should be asking themselves is, in what equipment, so Steris and Getinga, for example, are large manufacturers of sterilization equipment, and how do they measure their carbon footprint? And some of it is also chemistry related. So what are the opportunities, I would say, also for low temperature steam sterilization is another part of this equation. So the energy risk associated with creating the steam, and then the temperature at which, if there's a low temp sterilization opportunity for use. So it's really complicated, and I would say not easily measurable, I would say, unless you have a really forward-thinking sterile supply department, which if you do, please put me in touch with them, because I think that's part of the unmet need and the unmeasured and unquantified part of the conversation. The other piece I would add, is just what requires high-level disinfection and what requires sterilization. So are there probe scopes that perhaps have a equally efficacious high-level disinfection opportunity that is then shifting away from needing to go to your sterile processing department where they're sterilized? So that is also another dimension of equipment inventory and who's using what for what purpose. I hope that sort of skimmed the surface in answering your question.
Thank you. Yeah, no, that's very helpful.
So I do want to, I thank you so much. I'm an academic generalist at Women and Infants, which is in Providence, and we have a specialty standalone hospital. One of the things I think that we're seeing across the country in general is that payment for OBGYN services is really low in comparison to many other specialties. So our hospital's very much struggling financially. So when I do try to bring up these issues, the longer term benefits, even if financial, are being trumped by the shorter term needs of funds or not spending. And so I think that's one of the challenges that I've been having of trying to bring this perspective. The one thing that we were able to do is reduce our red bag usage, because I think there's a financial incentive to that. But the other things has been a little bit more difficult. The thing that I do want to bring up that I'm excited about is that, so I'm also do a lot of work with the American Medical Association, and while they have been embracing the impact of climate change on health outcomes and healthcare access, one of the things that they just started doing is looking at the impact of the healthcare system on the environment. And there's actually a report coming out, I believe, at either the next meeting in November or next June, looking at this. It's not new or novel, but it is for the AMA.
Right,
So
right, right.
I'm very excited to be able to, and once I see this report and it's released, I'll definitely bring it back to the group. But just wanted to share that good news that it's at least being appreciated and hopefully adopted.
So Heather, are you on a committee at the AMA that helped to draft this?
I am actually one of the ACOG delegates to the AMA. So I represent all ACOG members at the AMA. And we have actually people who are ACOG and OBGYN on their scientific council. And we have a few people who are also running to bring more voices to it. But there is a person who is very much committed to this. Her name is Ilse Levin, and she's on the board of trustees, and she actually represents the AMA to a number of the national and international organizations. And she is a proponent for this. And she brought me into this world a few years ago. And so she is also someone that we can also reach out to because she's just got reelected for her second term with the board of trustees. And it's ILSELEVIN.
That's awesome.
Yeah.
And so glad to hear that there's kind of more momentum. I think part of, just to comment on that for a second, I think that part of the work for all of us is bringing kind of the organizational momentum together from professional societies. So for me, that would be the Society for Healthcare Epidemiology, Infectious Disease Society of America. And so I think all of that will only help, I think, bring strength in numbers and coalesce, because I think, I hate to make this analogy, but sort of like antimicrobial stewardship was not quite on anybody's radar for some time. And then there was a lot of organizational momentum at a certain point about, we have a problem, it's silent, and so it's difficult to acknowledge, it's difficult to see, it's difficult for it to be aligned because there's not much short-term that we see in the short term as reward, and a lot of individuals were making the long-term message. But again, to your point, Heather, really hard for kind of people in leadership and administrative positions to often imbibe that. And so because of many other competing agendas. And so I think that, just taking a play from that playbook, at least in my own work and career, seeing how stewardship at a certain point had to make it on everybody's radar, and there was at least a comment about it somewhere, has been extraordinarily helpful to that effort in moving that mission forward. But to your actual question about how to get, how to bring that longer term message when there's so many other shorter term competing agendas and priorities, it's basically what I struggle with every day in my day job. And so I don't think there's always an easy solution. I think, of course, to your point, when you can make the financial impact align, it's a no-brainer. So I always look at that as a first step. And that, sometimes it's not a one-step process. I often say, maybe there's not this financial incentive aligned, but there's a very near term or a second piece of this that might be related or adjacent to this topic that could help us. So I'd say any and all related financial incentives. So I think a good example might be, the red bags, for example, but then are there other supplies, right, associated with even transporting reusable devices that you can buy in bulk via your group purchasing organization. So I'd say any and all related financial incentives would be point one. And then point two, similar to stewardship, I think we have to say, which I say basically every day, it's not going away. It's not going away, right? You're going to have to deal with this problem. And if you aren't forward facing in dealing with it now, you're going to make a mess for your future self in 1 year, 5 years, 10 years. That argument has gotten a little bit easier in that, you, in addition to the financial argument, the other argument that I also use is the regulatory one, right? So the Joint Commission is coming to the table. They have a sustainability, metric that they are going to be using. it's not finalized, it's complicated, but it's not going away. It's only going to be, more sharpened in the years to come. And similar story that happened with antimicrobial stewardship, right? Not only now is there a metric, there's a CMS requirement, and now that requirement has $25 million attached to how you report it, right? So the financial metrics will come, the regulatory metrics are coming. And that is where I would say really partnering with your procurement and your supply chain team, because they may not, you may not see the sort of the one-to-one, red bag analogy, but they may see something in the value chain that might be closer by, that will really help to align finances. But I share your difficulty, and I think that will be ever present for us in this work, unfortunately.
Thank you. But I think that's a really good point, is to not just go to either the finance or the higher ups, like to kind of go to the source and see if where there might be something that we can exchange or do differently at that point, where there isn't as much a financial implication.
Exactly. Everything, I'm always astounded, and I do this, right, that how much flexibility and contractual relationships and vendors are part of the equation as to what we use in our facilities. And some of it is, a little bit more fixed for different reasons, but some of it is not. And so there's always, it doesn't hurt to ask questions. And so usually my frame of mind is to, as you can probably tell, is to ask a lot of questions.
Thank you.
Those are great questions. And I have a couple. I'm like debating which one do I want to ask you, but I'm going to ask you a bigger picture question, Preeti. So for clinicians wanting to make changes more broadly and maybe not just in their institution, what organization do you think needs the most physician input? Is it the FDA? Is it the EPA? Like, as OBGYNs, we know the OR, I feel like that is the big thing. We know OR, single-use devices, and want to make changes. Like, where can we best make an impact, thinking about everything that you've talked about?
Yeah, I think if we're going to approach this from the device route, which I think is a fair amount of the impact that this group could help with, it's the FDA. Mm-hmm. Because that is really where the conversation is happening about making the technical information reports and standards that go through an organization called AAMI, which is the American Association for Medical Instrumentation, AAMI. And so that is what the FDA references when the FDA says, hey, device manufacturer, you need to have a validated IFU for how to disinfect and sterilize your device. And so it's the FDA that really needs to be, I think, have everybody at the table to say, yeah, we really need to get manufacturers to not just promote single-use devices. We really need to get manufacturers to have devices with clear, easy to follow, not incredibly complicated instructions for use about how to disinfect and sterilize. And then I think it's the FDA that has the power to partner with the EPA to say, we're going to be at this table with you and represent the entire medical device community. I think when you zoom out and you look at medical device regulation in general, it has gone through a lot of changes, a lot of complexity, I think, about who exactly is managing it all at the FDA level, because there's so many other components like RFID tagging and safety for actual use in patients apart from the infection prevention risk. And so that's where I'm hoping to really put the most emphasis and energy. And then I would say they are the ones that really can lead the conversation with the manufacturers. So as physicians, I think if we have interest in, or we partner with manufacturers for equipment, that's another real opportunity to have that conversation. And you know, I think that's also untapped, because I think, you know, I think we're prone to seeing manufacturers as kind of over here doing their thing, but that's a conversation we could be engaged in. And I think certainly for all of you who use devices every day, certainly could have a very meaningful conversation, certainly more meaningful than I could to some extent, as end users.
Well, that is a great answer. And I'm actually, my next meeting has to do with like writing a memo for the FDA. So great. Good momentum. Question that I had is, okay, kind of taking a step back then into our own space, and Heather and Maria have already kind of been asking about this. You know, when we are bringing that cost, you know, fighting that cost piece, like there's so many changes. Even at my institution, the urology department just switched at one hospital from reusable scopes to disposable scopes because of cost. And even though some people brought up the argument, you know, the carbon footprint argument and no changes in infection, that was the bottom line. And so, you know, if you could like have a one-liner, you know, what would be the takeaway when you're, you know, in these meetings, you're at the table and they're still like, no, we can't beat this cost, which is short-sighted because it is short-sighted, you know, the long run, it's cheaper. Like,
So,
you know,
so my answer is usually like zoom out, because I bet that it's not just the ureteroscopes, right? It's that's where I feel like somebody, and it would be really powerful if it was almost coming outside infection prevention to say, what's the scope inventory for the entire institution and what's being used, right? Because I bet you that's actually a very complicated question. And nobody weighs it like that unless you're sitting at the level of procurement or the level of clinical engineering or the level of the group purchasing organization. Because the urology scope in your example is like one fraction of the conversation. For example, okay, who's the contract with? Is it Carl Stores? Does that contract include preventative maintenance for those scopes? What else are we sacrificing in this whole contract by switching from, you know, the reusable to the single use? And so that is where I think there's strength in having somebody zoom out, because I bet it's just not about the urology scopes.
I mean, yeah, you're right. I don't know the whole scope, but that's very interesting thinking about, right. I mean, there's a maintenance piece, and are they saving money there? Is that a part of it that they're not, but you know.
What else is in that contract? Has anybody looked at that contract, right? Again, asking the questions. And so oftentimes that decision can be made in a silo. And so I am constantly encouraging kind of chiefs of service and clinicians and clinical engineering colleagues to say, zoom out, and what is the entire footprint? What is our entire inventory that we're purchasing, and who's managing it? Who's managing that inventory, so that, you know, if you make this small change over here, what are we actually doing to our entire footprint? And the other piece I would say is, can this be a temporary change? So shortages happen. You know, manufacturers go down for a variety of reasons, and there's a tempting reason to switch to single use. Maybe that single use switch can be short-term or temporary while XYZ is happening. That I think happened with, I think, some urology scopes in a few years back in 2022.
Can I ask
That's really helpful.
Quick question. Did you say that that the reusable gowns are one of the best LCAs for carbon footprint?
Certainly, like, there's a lot of evidence that using reusable gowns has a lower carbon equivalent than single use. Now, somebody's going to ask, who's your launder and what's the transportation cost of those gowns to that launder?
But doesn't the LCA incorporate the transportation?
That LCA did, yeah.
Because the second part is those gowns that we currently use, the disposables, have a lot of plastics in them. So twofold.
Yep.
Okay. So if someone were asking like, oh my gosh, I just want to try to do one thing at my institution, would you say that might be the highest yield?
If it's an institution that doesn't, I would say, this is a little bit of my IP hat on, but if they're still using gowns and gloves for MRSA and BRE colonization to begin with, that might be very ripe opportunity just to decrease any and all use, right, of gowns themselves. That will make the second part of that conversation a lot.
Yeah, I was thinking
effective.
more like the operating room.
Yeah. Oh, yeah. Easy for the operating room to definitely ask that question.
Okay.
Well, it's complicated, I would say, with the operating room, because most of the, I mean, all of the, this is getting technical, but again, it's in the questions, right? So the gowns themselves have a rating system for splash and spray risk. So they are graded by that
Heard
risk.
about this, yeah.
And so there's a certain gown that's only used in kind of sterile settings and operating rooms in particular. I would say more not in the operating room, but like perhaps when you're on the floor or, you know, doing a delivery, for example.
Are there PFAS in these gowns if they protect from spray? Now I'm thinking there's plastics and PFAS.
Yes, that's a really great question. So you could go down any number of rabbit holes. Probably yes for the grade 4 gowns. So again, that's where I think like we're never going to escape all of it, right? Like we have to accept that some of this is with us in healthcare. It's about trying to really in a nuanced way, risk stratify together. Where do we need this? And where should we really have an honest conversation about minimizing impact?
Well, I think that is a great place for us to stop. Boy, I feel like I've written like pages and pages of notes per usual. So thank you so much for joining us today, Preeti. I think that we've all learned so much, and you know, Heather hopped off and thanked us also for the talk. So we're really excited that you were with us, and if it's okay, we'll also share it with our larger audience. I feel like people access our webinars all the time on the website, and I'm really excited for your new, the new publication. So please do, send it to us, and so that we can also share it widely with our group.
Thanks so much for having me, everyone.
Have a nice day.
Thanks.
Thank you all.
Nice to see
Thank
you.
you. Hi.
Hi.